So thank you so much coming and listening to the story, and I very much will link it with the story what you heard from Grace earlier this morning. So the case for pituitary tumors. Just to clarify, we talk a lot about pituitary, so I just wanted to show you now you are an expert on MRIs, and I'm just trying to find my mouse here. Does it actually? Oh no, you need to use this one. Oh, sorry. I need to go back. Yeah, so this is the pituitary gland. This is on an MRI, and this is just with a drawing for you to understand where we are. And the pituitary gland has two parts. This is which makes some hormones which are important for growth and thyroid function and function of the adrenal glands. And this is the posterior part, which is very important for water household. So we talked about thirst and issues with that. So that's the part which is important for that. And here are the hormones of the anterior part, so the frontal part of the gland. And these hormones, if you have a tumor making too much of these hormones, then you have various diseases. So you have too much growth hormone, you have acromegaly or gigantism if it starts in childhood. And these are the other diseases. In children, it's actually mostly we see these three diseases: prolactinoma, acromegaly, and then Cushing's disease, which is also a very devastating condition, especially in children. And this is the MRI we talked about and the important structures which Simon already pointed out, that this is the nerve for the eye. These red blobs are the main arteries, so if the surgeon is not careful, they could be damaged. And this is a gland in the middle. This is how it looks in normally. But this is how it looks in patients, and these are all kind of teenagers. This is a 17-year-old, and this is also a 17-year-old. She's already very, very tall, and here you see their tumors. So compared to the normal pituitary, this is the tumor of this girl here, and this is a tumor of this girl here. So these are really, really devastating issues within this childhood period or teenager period, kind of completely wrecking their lives. And this is another case which was looked after by Helen, and I was a little bit also involved. So this was a 12-year-old boy coming with 4 years history of headaches, which were more or less ignored, exactly like you heard from Grace, that she had the headaches, but kind of the doctors didn't know what to do with a child with a headache. And he also was very short for his age. And then by the time she got to the pediatric endocrinologist, the tumor was this size. So now you see it, and here is in the lateral view, this is in the frontal view. And he had very, very high level of one of these hormones called prolactin. So it was 54 times higher than the upper limit of normal. So that's very, very high. And the tumor was operated, and you see these brown little blobs here. So in an average tumor, we may see one of these blobs among that many cells of the tissue. And in this boy, you see there's a lot of brown blobs. So this will suggest that it's a very aggressive tumor. This brown staining here is a staining called Ki67, which suggests that this tumor is growing aggressively. What was sad about this case, and this is one of the things we would like to kind of avoid, is that he had a grandmother who also had a pituitary adenoma, and not just that disease, but had two more diseases. She had high calcium levels, which usually due to a tumor of another endocrine gland in our neck, and also had a tumor in his abdomen in the pancreas. And these three issues, the pituitary, this tumor in the neck which causes calcium problems, and then the abdominal tumor, gives you a diagnosis immediately, which is called multiple endocrine neoplasia. And that's a genetic disease. And if this would have been properly investigated in the grandmother, then the family could have been screened, and this boy would have been picked up much, much earlier stage and could have been treated with drugs and may not even needed an operation. So what is important that doctors recognize patterns, and if they recognize a pattern, then they can act on it. And really the most important thing to educate medical students. Many of these diseases are rare diseases. They may not see a patient ever in their lives, or if they see the first one, the only previous time it would have been their medical textbooks. So our aim with rare diseases, which many of the diseases we're dealing with here, is that we need to do education at the medical student level, but also re-educate doctors later in life, because many of the doctors who are consultants today, when they were in medical school, this gene, what caused in this family the disease, was not even known. So of course they haven't heard about it in medical school because it has been discovered only in 1997. So education and re-education is very, very important. So I just very briefly talk about the genetic aspect of pituitary adenomas. The vast majority of pituitary tumors are not genetically determined, but a small but significant percentage is. And in children, we see that a lot more than in adult cases. And therefore, although it's super rare in children, the pediatricians need to know about this. And when we talk about a genetic disease, a genetic change, we need to think about it in three kind of level. One is that there is a genetic change which is everywhere in the body, in every cell of our body. Another way, when we only have it in some of the cells of the body, but not just in one place, but in a couple of places. And that's what we call mosaic. And then we have a third type when there is a genetic change only in the tumor. And we kind of discovering these changes increasingly, and now there are a lot of treatments available based on these genetic findings, especially in this world, various types of lung cancers and leukemias, and now can be treated really, really well because they found the change in the tumor and they can make drugs exactly for that particular change in the tumor. But here we talk more about the germline cases, which means it's everywhere in the body. That means also in the ovaries and the testes, which means that it can go to the next generation. So the previous boy was like that, where the gene came from the grandmother. So these are the different types of pituitary tumors which can be inherited, and I will not talk about each of them, but I will mention just this one here, which is called AIP, which is a name of one of the genes which is associated with pituitary tumors. But there are all sorts of other ones which we don't have time to talk today. But what I just want to show you that the ones with a yellow star are happening in children. And even within these yellow ones, the ones which can cause high growth hormone levels and therefore gigantism are 14 different genetic alterations can give you gigantism. So to turn it the other way around, about 50% of the patients with high growth hormone levels in childhood has had already an identifiable genetic cause, which means that every child who has high growth hormone levels should be sent for genetics, because there's 50% chance that we actually will find the cause of their disease. And that is not just advantageous for their own care, but very advantageous for the rest of their family. And that's exactly what you heard from Grace, that in her family, how it was. So children are different from adult pituitary patients, and here I just listed a couple of issues why children are different and why we need specialist child-specific care for these patients. So they have different presentations. The way they present, it could be very different from adults. They usually have larger tumors than adults, or the percentage of patients with larger tumors is a lot higher. They are more familiar, genetically determined, as I mentioned already. Simon pointed out how he goes through the nose. There is a space there which he approaches the pituitary gland, and that's more difficult in children just because the head is smaller and this sphenoid sinus is not so well developed in a small child especially. So you really need an expert surgeon. The children are usually less responsive for medical treatments. We have certain drugs we can give to pituitary patients, but they are less responsive. And then the disease, of course, interrupts the normal puberty, the normal development of the child, may result in infertility. And they also can have very tall stature, or they can very short stature. So that's important for the rest of their life. And we shouldn't forget that there is quite a high level of psychological burden, and you probably can talk about it more than I do, that being just different from the peers, having different experiences, needing different medical care at all. So there's a lot of things different. So we recently published this guideline, which Helen mentioned earlier, which was kind of work over 8 years, and this is the first ever in the world to have a pediatric pituitary adenoma guideline, and it just came out in Nature Reviews in kind of 2 parts. So why comprehensive expert assessment is important? And this is the case, which you heard already from Grace. So this is kind of how I heard about her. She wasn't even 7 at the time, I think. She was tallest in the class by far, and she had headaches. And then in September 2008, the night she mentioned that she scrambled into her parents' room, vomiting all over the bed and not being able to open her eyes, she had what we call a pituitary apoplexy. So that's almost like as Helen called it, you know, the pituitary gland kind of blew up and she couldn't open one of her eyes. And this is the scan you already seen. So this is the tumor here, with the apoplexy. So it's clearly it was really a life dangerous event if it's not treated properly. And this is Grace here, and this is her mother, who had a prolactin secreting tumor when she was in late teenage years. But we should remember that this mother had an uncle who also had a prolactinoma, and then had another uncle who was a giant. He was over 2 meters tall. And there was a first cousin who had acromegaly, so started the pituitary tumor. So Grace was the 5th person in this family. And you heard that her parents were told that this is not a genetic disease. I mean, looking at this tree, it's pretty obvious that it's a genetic disease, right? So I marked with yellow the people who are carrying the gene, and at the time when I drawn this figure, her brother was unaffected. But since he was followed up, and since now we know that he's also affected. So some people with this gene can remain unaffected, but other people will develop. And you see that in this family, quite a few of them did. So the family members can be screened for the mutation, and the ones who are positive, they need follow-up, and they need careful follow-up, especially in childhood. And again, this is something which is not well known enough. So I just want to show you a little bit about her wider family. So I show you here, this is a cousin of Grace. It's called Charles Byrne, and he lived in the 18th century. And this is actually twins with gigantism. So he was a giant, and these are twins with gigantism, and these twins were his first cousins. And this picture is in the National Portrait Gallery, and everybody can look at it. And just looking at this picture, you already know that this is a genetic disease. You don't need to be a doctor or take any DNA samples to know that there is a very rare disease called gigantism, and then twins having gigantism, and all 3 of them being cousins. There's no doubt here. But this guy actually is in a museum in London, the Hunterian Museum, and this is his skeleton. And what we found, that we found 4 families initially 4 families with family members with gigantism, and this is Grace here, so this is Grace's family, but we had 3 other ones, and all of them were from Northern Irish origin. And this is one of the family member from one of the other patients, looking at his kind of cousin from two centuries before. And what was interesting, that we put these families on a map. Then this is a part of Northern Ireland, and this is the place where the giant skeleton, the guy whose skeleton is available, was born. This is where his cousins were born, the twins. This is when one of our 21st century patients was born. This is the other one with me on the photograph. And this is where Grace is family from. So all within just a few miles from each other. So we got a permission from the museum to actually look at the genes of this patient from the 18th century. And you see that a molar tooth is missing from here. That's because I asked the museum to remove it. And these are, actually they removed 2 of them. And I was just worried. I asked them to remove from both sides 1 tooth, because I was worried that maybe during the 200 years of the museum, there was some very keen museologist who might have replaced a missing tooth with a tooth from another skeleton. I was so worried about it. So I asked them to remove 2 teeth from 2 sides. It couldn't have happened twice. And then what we found, that there was a mutation in these 4 families in this gene called AIP I mentioned earlier, and it was also found in the museum sample. And then we looked at some markers around the gene, and we found that all 4 families had these markers. And then when we looked at the giant also had the same markers. And to have the same mutation and quite a bit of the chromosome being exactly the same in these families, the only way it's possible that they are all related to each other. They are all cousins of each other. So this is a map of, just a few years ago of the families we found with all the same mutation. Since then, we have a few more from Scotland, but we also have now 3 or 4 families living in North America. And as you know, a lot of Irish people emigrated to North America. So I knew that we will find them, and indeed we found them by now. And then the next step happened when this case was referred to Helen Spoidas's pituitary clinic. And this is a case from Belfast. And this was a 9-year-old boy who had poor concentration, deteriorating schoolwork, mood changes, increasing stature, and practically by the time he was diagnosed, he was blind on one eye. And he had this 4-centimeter tumor in the middle of his head. And of course, he also had the same mutation, what's these other Irish families. So this case prompted us to actually go to the area in Northern Ireland and collect DNA samples from the local population, the people who live in that area I showed you on the map. So here you see that one of the patients was helping us, and this is the local genetic clinic, and these are my postdoctoral fellows and clinical colleagues, and we were collecting DNA samples for everybody who came to Tesco's on that day. So you want to buy some milk? Yes, but you need to give us your DNA. That was kind of the deal. And we collected almost 1,000 samples over 2 weekends on 2 different Tesco stores, in 2 little towns in that area. And we not just collected DNA, but we collected more stories. So there was a lady who said, "Are you here in the next half an hour?" And we said, "Yes, let me come back." And she came back with this photograph. This was her mother's brother. And then another guy, exactly the same story. "Are you here in half an hour?" "Yes." He went home and brought us this photograph. This guy was his grandfather's brother. And then we asked him, "How about this guy here? Look at that. This person has also acromegalic gigantism, maybe not as tall as him, but still very tall. Look at the size of his hands and his face. Definitely have acromegaly." So we have a village with people, 2 of them with acromegalic gigantism, and that was this person's family member. So we collected a lot of samples. This is the particular mutation we found in this AIP gene. And then at the time, and that was about 7 years ago, we actually found 18 independent families, and they all have the same mutation and the same kind of markers in the gene, suggesting they are all cousins of each other. And Grace here is one of these first families. And we were thinking that how long ago this gene is in Northern Ireland. And if we put the 18 families together, and we did some very clever genetics, and we found that it was about 100 generations ago. And 100 generations, if you calculate roughly 25 years, people having their children at the age of 25 years, so that's about 2,500 years ago. So this gene, the first person with the gene, lived about 2,500 years ago. So all the stories you know about Irish giants are probably due to this particular gene, and somebody in 1813 wrote about this, that in Ireland, men of uncommon stature are often seen, even in gigantic form and stature, occur there much more frequently than in this island, which means Britain. And he suggested there is some peculiarity there, and I suggest it's due to this gene. So just to prove you that there are lots of Irish giants, this is an Irish giant in the Dublin Anatomy Museum. This is another one called Patrick Cotter. This is another one, 7-foot-tall women, not just males, but females can be also having this disease. This is another one from the early 20th century. This is one from the 19th century. This is from the 18th century, a beautiful painting of a soldier who went to the German army who kind of collected giant soldiers. And what we need to do is what we did in this other family, which is just screening the family members, identifying who are the carriers, identifying the carriers' children, whether they have the gene, and then just do something very simple, which every endocrinologist can do, which is a simple blood test and an MRI scan. and then we will identify the patients. And this particular family, we identified 5 affected subjects just based on this proband, and then there was a third cousin also here with a disease. I'm finishing. So 10% of the people who apparently were healthy actually had the disease, but we can only do this if we follow up. So this is the folklore of the Irish giants, and this is reality. We now know why you have that folklore. And I just would like to finish with this particular photograph here from Jonathan Swift, who lived in Dublin, but he spent a summer in this beautiful house called Lowry Manor in 1720. And this is the location of this house. And he was writing a book that summer when he spent in this place. And I don't know if anybody can guess the title. Exactly. He wrote that book while he was in this house and clearly got the inclination from the locals. So with that, I just would like to mention that we set up a kind of a charity and a website for patients with familial pituitary adenomas. And thank you so much for your attention.